whenever I have a complicated thyroid cancer case. So I'm so happy to have him share his talk about what to do when we get stuck with radioiodide, non-sensitive but serious thyroid cancer. Thank you.
Thank you, Robert. It is an interesting journey because many, many years ago, I had nothing to offer. We had doxorubicin that nobody wanted to give, and here it comes. We have so many drugs that we can use. So thank you so much. It's quite a change. It just makes me feel old. Okay. Okay, I have it. Okay, can you hear me? I mean, and can you see the slides?
Yes. Mm-hmm.
Okay, so what I want to cover today, I want to cover the redifferentiation of the radioiodine refractory differentiated thyroid cancer. And so this is kind of a task that I, as a medical oncologist, many kind of come across, even though at this moment, there is no FDA-approved strategy that we can kind of implement or we can use. It seems to be an easy task initially, but it's not that easy. And I'm going to try to walk you through the dilemmas that I do have as a medical oncologist. And actually, this is the task that has to be coordinated, not just with me, but with nuclear medicine people and then endocrinologists. So it involves quite a coordination and explanation. So I want to start with two cases. So the first case, and we're not going to be solving this problem. So this is a gentleman. Actually, he is a nuclear medicine doctor. So he reads iodine scans, and he was diagnosed with the papillary thyroid cancer this year. He underwent total thyroidectomy. Unfortunately, he has pulmonary nodules in the settings of elevated thyroglobulin, and he obviously underwent lymph node dissection, and he underwent total thyroidectomy. So this is a treatment naive or iodine treatment naive patient. And obviously we can imagine that obviously his iodine scan is negative. So obviously there is no uptake in his lungs. And we know that he has those pulmonary nodules suggestive of metastatic disease in settings of the elevated thyroglobulin. So obviously the question here is, if we're gonna go with the typical route of giving him radioactive iodine, is it going to be sufficient? Is it going to be enough? Or can we kind of enhance the potential response from additional drugs that can be used? So, and what we did for this gentleman, we did the genetic testing, and he has a BRAF mutation, but when it comes to any kind of mutation, the problem is not just about the having or not having the BRAF mutation. It's sort of like the number that kind of follows the BRAF mutation is very important too. It's sort of like with the lock and the key, me trying to open your door with my key, even they look the same, is not going to do the job. So here is kind of the same concept. So here we have a patient who is iodine naive, and we kind of trying to find out if there's anything else that can be done to increase the response of achieving a remission in this patient. And the second patient, obviously, as you can imagine, this is the iodine refractory. So somebody who underwent total thyroidectomy many years ago, he received high dose of iodine. He had a recurrent disease that was removed by our surgeons, by Dr. Jandon. But unfortunately, he still has a residual cancer that cannot be surgically removed. And obviously, knowing that he received iodine in the past, the question is, can we use the iodine again, knowing that he received a high dose in the past? And is it going to be effective? So for these patients, we were kind of considering, a few treatment options. And one of them obviously was using BRAF inhibitors with the radioactive iodine, even though it's not FDA approved. The other option was using Lenvima, which is FDA approved, and with response rate of 65% and a progression-free survival of 18 months, we can use BRAF inhibitors, knowing that he has a BRAF mutation, even though they're not FDA approved, instead of Lenvima, and the response rate is 40%, and the PFS is 18 months, or radiation. So there are quite few treatment options for these patients, and obviously you want to pick the one that's going to be most effective for this patient. So why we do it? I think the reason that we entertaining using the iodine again, because obviously the benefit of achieving the complete remission, and obviously the complete remission in the thyroid cancer is going to be no evidence of thyroglobulin elevation, no evidence of immunoglobulins, as well as a radiographic evidence that there is no disease. So there are two recent studies from Dr. Tuttle and Weissman. So we know that patients that they achieve remission, obviously these are the patients that they're not going to be dying from the thyroid cancer. Patients they're not going to achieve, for which iodine is not going to work, that we're still going to have some remnant disease or evidence of the persistent disease of iodine cancer. These are the patients that eventually, obviously, they can die from the cancer. Even though the percentage is not high, it's about 6 and 8% with the median follow-up 7 to 10 years, but still, obviously, this is something that we should improve. So the benefit of achieving remission is that obviously we can minimize the risk of disease-specific deaths to zero. And obviously, we have to understand that the follow-up is quite short. It's just 7 to 10 years. But as this time is going to continue, we're going to have the longer follow-up. There is a possibility that obviously those percentages are going to go up. And obviously, there is other benefits. The other benefit of achieving remission when we use the iodine, obviously, is the fact that we can have a high-risk patient based on the ADA criteria that's going to have a complete remission, and we can reclassify those patients as a low risk. And obviously there are some implications of this. Obviously the aggressiveness of the TSH suppression is going to be different. The intensity of the screening that we're going to be doing obviously is going to be different. And obviously there is a psychological or kind of a stress kind of burden on the patient, thinking that obviously there is a possibility that the cancer can be back. So those are kind of the benefits of using the iodine, with hopes, obviously, it's going to be successful. But as you know, the problem is that the iodine is not really effective 100%. And there are, I would say, like two categories. The categories are kind of histology based. We know as we're going to be moving from papillary thyroid cancer into anaplastic thyroid cancer, closer to anaplastic you're going to be, the chance of responding to the radioactive iodine is going to go down. And obviously we think about the Toll cell, the Hürtel cells. Obviously there are some histologic implications for which we know historically that the iodine doesn't have a high risk of achieving remission. Those are the one pool of patients. And there is another one that we know that based on the TNM, and this is the data from Dr. Tuttle and from Brazilian data, when they kind of identified the high-risk patients. And the reason that it was done because they were planning to design a study where they used the salatumab. So basically, they used this data to kind of identify patients that are going to be considered high risk. And as you can see, that obviously, if you have the T4 disease, that the chance of remission is 13%. And as we know, those patients, most of the time, they present with the N1B disease. So obviously, understandably, N1B has the same remission rate. T3 patients, many times they present with the lymph nodes, but not the one in the mediastinum, but just in the neck. So that's why the percentage of T3 and N1A is kind of similar. But obviously, if you have no lymph nodes, the chance of achieving remission is 60%, but it's still obviously, I would say average, it can be improved. So we have those patients that sometimes we are considering as a high-risk patient, and obviously we're concerned if the iodine is going to be an effective treatment. And obviously this is because obviously we know even in metastatic settings, the difference is in survival between the patients that are going to have the iodine uptake and the ones that they're not going to have. So obviously the ones that are going to respond and the ones that are going to have the uptake, they're going to live longer. So this is for metastatic settings from Dr. Durant. Very similar slide kind of showing that the ones that are going to have the negative images, obviously the survival is going to go up. So what is the kind of the biology behind this? So as we know that thyroid is a unique tissue that is going to absorb the iodine. And it's because there is this protein, it's a symporter, this is the iodine symporter, that it is in the cell membrane that obviously is responsible for the uptake of the iodine from the bloodstream, oxidizing and obviously hormone production. But you can think of it as an easy task that obviously the iodine comes in or the protein is being produced. But I was kind of thinking about this as even the COVID vaccine delivery, that it's not an easy task because we kind of think that the COVID vaccine is going to be produced and magically we're going to get the shot today. But there's multiple steps that have to take place in order for this vaccine to be successfully delivered. It has to be produced, it has to be transported from, in terms of Pfizer, from Europe to United States, and has to be distributed. And it's kind of the same task with the importer. It's not just about having or not having or stimulating the production or not. The gene cannot be silenced that is responsible for production of this importer, so then it's going to be present. There is a transcription process, there is a translation, and then subsequently this protein has to be delivered to the cell membrane. And sometimes it's not just about the activation of the gene, but there are multiple steps. And if one of those steps is obviously not very efficient, then obviously it's going to translate to iodine resistance or absence of this protein. So having this in mind, so this is the slide that kind of shows how complicated it can be a little bit. So there is this gene called SLC585, and this is the gene that is responsible for the production of the protein that I just mentioned. And as we see in this slide, in the well-differentiated thyroid cancer, which is on the left, you're going to have the presence, you're going to have the production of the protein is going to take place, but also this protein is being obviously transported to the cell membrane that iodine successfully can enter the cells. And in this case, obviously, it's stimulated by the drug, but we're going to go over this. But obviously, cells, many times they lose this, and this is the time when the cancer, the thyroid cancer, is not as differentiated. So as we kind of said it, the closer to anaplastic thyroid you are, the less differentiation that you're going to have. And obviously, it's going to be consequently, obviously, subjected to the iodine resistance. So, but in this case, obviously, we have this, that we can use sometimes the drugs that kind of bring the iodine back into the picture. And obviously the hope is it's something that was iodine resistant, now it's going to be the iodine sensitive. But I want to use the metaphor. I'm going to kind of tell you maybe a little bit strange, a private story. And it's kind of a little bit sad, but I think it's going to illustrate something. I live in New Jersey and my house was robbed. What happened? The thieves, they got in, they kicked the door, they got in, they cut the wires of the alarm system, so they were clearly inside, but the alarm system went on and the cops were on the way and they had to leave. So I have them on the camera. So what I'm trying to say, nothing was stolen. So I don't want you, because we're getting sometimes the illusion that with the image that we see with dabrafenib, that all of a sudden we have this iodine uptake. So the iodine was delivered to the cells, like those thieves that got into my house, but they stole nothing. So the question is, not only we cannot kind of be misled by the image, it cannot just be just the iodine is present and probably is going to do the job. We don't know. So obviously there is always a question when we're going to see those studies. Okay, the iodine entered the cells, we made it active, but what is going to do to the cancer? So obviously this is just the first step. So obviously there are some drugs in this complicated process that what they can do, they can restore the differentiation that's going to manifest in the increase of the iodine uptake. But it's going to be also interesting that many of those patients are going to have the elevation of the thyroglobulin. And this can be a little bit misleading. You can think that, okay, this is the tumor marker. This is something that we measure. This is how we measure the cancer, the method of quantification, how much cancer is back. But at the same time, we know that if you're going to have poorly differentiated cancer, or you're going to have the anaplastic thyroid cancer, the thyroglobulin is not going to be high. So when you're going to be kind of moving or shifting the poorly differentiated cancer, you're going to make it more differentiated. So consequently, obviously the thyroglobulin transiently can go up. So this is sort of like a marker for us that intervention with any kind of drug to restore the iodine uptake is going to be successful. So this is kind of to illustrate that it's not an easy task. This is kind of the map of the drugs and the pathways that they show some potential. And when you're going to see the blue drugs, these are the ones that were successfully tested. And the green ones, there is some trends, and mostly they were tested in the cell lines of animals. But as you see, there are many, many, many drugs. There's many, many, many potentials. So you can ask, if we have so many pathways, so why we don't use it? So it's not really that complicated. This is not really that easy. So many times, unfortunately, as we can imagine, that certain process is not dependent on just one mutation and the activation of just one pathway, because the cells always kind of find the escape mechanism. So you see all those drugs. It's something that kind of was all, for me, it was very striking that there are so many of them. So as we're going to go through this, you can imagine, so, okay, if I'm going to use one drug out of those drugs that are on the slides, and it's not going to be successful, maybe we should combine them. Maybe we should kind of, the effort should be made into find this magical combination that's going to just overcome the resistance that we're going to be discussing a little bit later on. And there are drugs like lapatinib that we use in breast cancer. So as an example, this drug is going to be about $5,000. We have sorafenib. It is a TKI that we use in many cancers. And again, it's going to be about $3,000. We have the column of blue drugs, the vemurafenib, dabrafenib, cabozantinib, all of them going to be in the $5,000 range. And I have the reason to say it. And obviously there are demethylating agents. And again, this is another kind of the robbery type of metaphor. If I'm going to have a thief that I'm going to hire and I'm going to equip them with all those keys, and he's not going to be a sophisticated thief, even though if I'm going to give him all those keys and he's going to go inside the cell, and let's call him Iodine, his name is Iodine, I cannot be sure that he's going to do the job. Maybe he's going to go inside like those thieves that they got into my house and they're going to be forced to leave and they're going to do nothing. So there's no benefit for the patient. So this is one aspect. The second aspect is, as we're going to combine those drugs, the investment is going to be very, very higher. So to combine those drugs, the price of the treatment is going to go up. And obviously we shouldn't be focused on the money, but we know the cost of the healthcare obviously now is high. So the cost has to be justified. And obviously there is something else. There are some side effects. Obviously, as we're going to be making this a little bit more complicated, and it's like a cooking, right? Take a little bit of this, a little bit of that, with hopes that we're going to deliver the product or get the product that we're going to be satisfied. And obviously we're talking about the iodine sensitivity and iodine response. As you see on the slide, it's not an easy task. So let's go through some of those pathways and just let's see, obviously, what is the response rate and obviously, how effective they are. So starting with the drug called selatumumab. So this is one of the drugs that was tested. It's a MEK inhibitor. So from the previous slide, there is the RAS pathway with BRAF, MEK, and ERK. So this is the drug that was used in pancreatic cancer and also was actually tested in thyroid cancer on a notion that the BRAF mutation is present in about 40% of the papillary thyroid cancers. So there is some interest in this drug, and they said, okay, let's see if by giving this drug, we can obviously shift the cancer into well differentiated and we can increase the iodine sensitivity. So actually, Dr. Alan Hope from Sloan Kettering, just a few blocks down, he published this in New England Journal of Medicine. There was a study with 20 patients. He took patients, but they were not restricted to one mutation. So as you see, they took patients with BRAF, NRAS, RET, and wild-type mutations. And what they did, they got the PET scan that was preceded by the thyrogen injection. Subsequently, they gave selatumumab 75 milligrams twice a day. And it was followed by the thyrogen injection and the PET scan. And depending on the response, the patients were either assigned to subsequent treatment of the radioactive iodine, or if there was no adequate response, basically the treatment with selatumumab was discontinued. So I think about selatumumab sort of like a key. This is like this thief that opens the door for the iodine. So obviously you give it for 4 weeks because you want to make sure that all the doors are open and the iodine is going to be able to get in. And what was surprising, obviously, as you're going to see on the graph below, that patients with BRAF mutations, only one patient, one of 9, received iodine, meaning that he got an adequate response based on the PET scan, but 4 out of 9, they didn't. What was surprising is that not BRAF, but the NRAS mutation seemed to be most promising because all the patients, they received iodine and there was some kind of response. Red patient, there was one patient and there was one patient with the wild type. So overall, only 8 patients out of 20 they received the iodine treatment. And these are the results. So most of the patients, they had the partial response. So we have 8 patients here. Some of them, they had a stable disease. And you're going to see, you see that there is one patient with BRAF mutation having an excellent response, and there is one with NRAS mutation. So it's not like some kind of a shift towards just one mutation that it's kind of dominating and provides the better response. But what you're going to see in the section B is that after the selatogrel, there is a transient elevation of the thyroglobulin. So this is something that we're discussing, that as you give selatogrel, probably what happens that the cancer becomes more differentiated, and consequently there is an elevation of the thyroglobulin production. But subsequently with the treatment, as expected, this number should go down because the purpose of the iodine is obviously eliminate the cancer. And those are those very, very nice, obviously, pictures. But again, I'm a little bit skeptical because even in this study, the follow-up was a little bit longer, but they reported the patient at the 3 and the 6 months mark. So obviously, we don't know what is the long-term benefit of this treatment, even though the images that we see in front of us are very encouraging. Obviously, seeing iodine, obviously lighting up in organs or nodules that they were not positive on the previous pre-selatogrel scan, obviously they are very encouraging, but the question is, will they do their job? So having this experience, there is a phase 3 study that was done, and actually we're part of the study. So in this study, what we did, we identified patients that we defined them as high risk. And those patients, there were high T4s, high end status, so basically more lymph nodes you had, larger the cancer, you can qualify to be part of the study. And there is no restrictions based on the mutation. So basically they took all the patients, none of them was tested for any specific genetic mutation, and they thought that the mutation will not matter. Patients were randomized, so patients, subsequently after they underwent thyroidectomy, patient was already labeled as a high risk or no risk, and subsequently, patients were randomized 2-to-1 to the treatment with selatogrel, the drug that we were just discussing a little bit before. And the treatment was given for 4 weeks. It was followed by the radioactive iodine treatment. It was 100 millicurie. There is no any room for kind of change of the dose. And I remember that we had some kind of the discussions with our nuclear medicine friends, doctors, because sometimes they didn't feel comfortable for high-risk patients to giving just 100 millicurie. They wanted to give the higher dose. So there was a little bit of the pushback and discussion, but we put quite a few patients on the study. Subsequently, after they received the iodine, they continued the selatogrel for 5 days. And then the purpose of the study was to achieve the complete remission. And I'm going to just move to the subsequent slide and come back. The definition of the complete remission was basically that you cannot have any stimulated thyroglobulin. It has to be less than 1 in order to call it a remission. You cannot have any thyroglobulin antibodies, and you cannot have any structural disease with any standard images. And it was 18 months. Any kind of deviation from this, they said there is no remission. So going back to the previous slide. What was disappointing, actually, it was a negative study that, as you see on the right side, the addition of the selatogrel to radioactive iodine didn't change anything. The remission rate was exactly the same in the placebo group, and it was exactly the same in the treatment group. And there is no trend towards any kind of the genetic mutation suggesting that maybe there is a subpopulations of patients that would benefit from this strategy. So obviously, it was disappointing. But I have to just point it out that, having a treatment-naive patient, somebody who is labeled as a high risk, and was given the placebo, which is just radioactive iodine, obviously it was, in this case, it was 100 millicurie, the remission was 38.5%. So you just helping 60% of the patients. So I think that obviously there is a need for some kind of improvement, because we know what are the consequences of this. That if you're not going to have the remission, you have to be aggressive with the TSH suppression, the surveillance is going to be tight, and there is quite possible there is going to be subsequent treatments, whether it's going to be radioactive iodine, another high dose, or it's going to be something different. So I'm going to skip through this slide. So Since the previous study, it was the largest and the only phase 3 study kind of trying to answer this question, but because they didn't restrict patients based on the genetic mutation, so obviously some scientists, they said, okay, let's enrich this population. Let's test the same strategy, maybe not with the same drug, but we're going to give the medication only to the patients that are going to have this mutation. So here, Dr. Michael Rotherberg, he identified 10 patients with BRAF mutations, for which patients that receive dabrafenib, this is the BRAF inhibitors, this is the FDA-approved drug that is commercially available, and we use it in melanoma, given in the standard dose to all those patients. All those patients, they had to get the thyroid stimulation, followed by the iodine scan, and depending on the uptake, they either received the treatment or they didn't receive the treatment. So it's the same concept. So dabrafenib is like this magic key that opens the door for the iodine to be delivered and doing the job. And they used 150 millicurie for those days. So as you see that obviously it was successful in a way that, yes, the drug opened the door, and obviously the iodine was able to be delivered to nodules that previously, obviously, there was no iodine uptake. So this is kind of a success of that. And obviously, as you can see, some of those patients, they had partial response, but many of them, they had just a stabilization disease. As you can see, only 6 out of the 10 patients obviously benefited from this treatment. When I say benefited, because there was the restoration of the iodine, that obviously that the iodine was delivered to the nodules that were previously resistant to the iodine. But here is another caveat. So we talk about iodine as this perfect thief that is supposed to rob the house, but obviously we don't know if it's going to do it, because if the tissue is iodine resistant, you can deliver the iodine all day long and it's not going to do anything. But when you're evaluating the response to this treatment, obviously we want shrinkage of this cancer. So we want to see some partial response that is going to be long lasting. We want to make sure that the PFS, which is the progression-free survival, is going to be longer, and it's going to be subsequently leading to overall survival improvement. But the problem with this is also that the BRAF inhibitors that we give for a short period of time, they have activity in thyroid cancer. As you remember when I was showing you the clinical vignette, if I'm going to have a metastatic thyroid cancer patient for which I'm going to be using BRAF inhibitors, even though it's not FDA approved, the response rate is 40% and the PFS is 18 months. So obviously the question with this approach that we see with Dr. Rothenberg is, the benefit comes from BRAF inhibitor, and obviously a longer follow-up probably would give us the better answer, because if it's going to be a short follow-up, because BRAF inhibitors is given for a short period of time, it's not as a continuous treatment, then obviously it's going to be more convincing to say that the benefit comes from the iodine. But if the interval of the follow-up is quite short, the question is it the benefit of the BRAF inhibitor? Is it a benefit of the iodine? Or there is some kind of a synergistic effect of this combined approach? And obviously, we're not really getting clearly the answer, at least with the studies that were published so far. So again, another encouraging slide that, as you see, that obviously we see the nodule in the lung and all of a sudden it's getting smaller. But obviously the question is if it's going to be a long-lasting shrinkage or response, and it's going to be short-lasting. Another study, it's from Dr. Dunn and Alan Ho, it's a similar approach. And what they did, they used vemurafenib. It's the same family of drugs as the BRAF inhibitors. This time they used the PET scan with the iodine 124 approach is very, very, very similar. And obviously patients that they did have the uptake, obviously, they were the ones that received the radioactive iodine. And as you see, the evaluation took place 2 days, 1 month, 3 months, and 6 months. We don't have the long-term follow-up. So we have kind of the same dilemmas, such as what is the long-term effect of this strategy, if there is any benefit. In this study, so obviously, as you can see, that they have 3 patients with poorly differentiated carcinoma. There is some columnar tall cells. So all those obviously histologies obviously suggest an aggressive form of the thyroid cancer. And obviously having the BRAF mutation does not help. We know that the BRAF mutated thyroid cancer patients, this cancer is more aggressive, and all of them, they had the mutation. So they had 12 patients in this study, and only 8 they responded. So we have some patients that responded to the iodine, but didn't respond. They responded to the treatment, but they didn't respond to the iodine. So you see the black and the white columns, because obviously with the BRAF inhibition or BRAF administration, you're going to see the response even in the absence of the iodine uptake. What's encouraging in the section D is that some of those patients were followed for a longer period of time. There is one patient, patient number 6, that he was an iodine responder, that the follow-up goes almost to like 35 months, and he has a stabilization of the disease. Patient number 11, he has a partial response. And again, he is in a category of patients that they responded to the iodine. So obviously, yes, there is some kind of a signal, but obviously we have to ask ourselves, it is statistically significant, obviously, to kind of implement this kind of strategy in the clinical practice. So I just gather all those studies that kind of use the same strategy. So as you see, there are many of them. And what they have in common, all of them, they were trying to target the BRAF and MEK and ERK pathway. So it goes from the study of Dr. Alan Ho that we were just discussing. So only the response rate was only 40%, only 8 patients responded, 5 patients with NRAS mutation, only 1 patient with BRAF mutation, 1 patient with RET, and 1 wild type. And it was reported at 6 months. So, and again, it's a very short follow-up. 5 patients in partial response and 3 patients in the stabilization disease. The study that we were just discussing from Dr. Rotherberg, there is another one from Dr. Hillard. And again, using the same strategy. And as you see, obviously, all those studies, they have a very, very small number of patients. This is one. Second, they use the BRAF inhibition pathways, they use BRAF inhibitors. And again, those drugs on its own have activity in thyroid cancer. And 3, the problem is that with all those studies, we have a short follow-up. So obviously, this is something that we don't know. What is the long-term benefit of this approach? And again, I want to emphasize there is a cost behind this. And I'm not trying to discourage anybody. There is a cost behind this. Logistically, it's obviously, it's kind of labor intense because there's many people that have to be kind of coordinated. So if we're going to go this route, I would always say that we would have the good justification for those actions. And I'm not trying to give up on those patients. So let's move. And there are many other, obviously, pathways that they look promising, but all of them, and it's impossible to kind of present all of them during this talk. All of them, they have kind of the same problem. Short follow-up. Many of them, they don't have any human data. It's just the cell lines or animal models. So just I know because you're kind of familiar with the PPR gamma agonist, obviously using for diabetes. So I just decided to, out of those many pathways that were presented on one of the slides, to present this one. So obviously there is some data suggesting that using those drugs like rosglitazone, pioglitazone, obviously they have the antiproliferative effect, but also you can redifferentiate the cancer with hopes that you're going to restore the iodine uptake. And Dr. Kibbutz, he reported a study in 2006 and 2009. They had 20 patients for which they received the treatment with rosglitazone. There was a response in patients, and obviously they received the radioactive iodine after, but the response was based on the decreased thyroglobulin and positive uptake. By the RECIST criteria, so this is something I use oncology. The RECIST criteria, for somebody who is not familiar, you have to detect the shrinkage of the cancer. So meaning if something was 3 centimeters, you have to see that it's getting smaller. But by RECIST criteria, no patient had had complete or partial response. It was mostly stabilization disease. So the question is there any benefit of this? So obviously, and we know that biology of those cancers sometimes is aggressive, is fast growing, but we know that many times the thyroid cancer can be slow growing. And is it really is this iodine really doing anything? To kind of talk about the COVID vaccine from being delivered from Europe all the way to United States in multiple steps, obviously, it's not just about production of the importer, but obviously there is a question if there is any other reason that obviously some of those patients, they iodine resistant. And there are some studies that it's not just the protein production, but it can be protein trafficking. So basically we have to make sure that obviously this protein is going to be delivered to the plasma membrane. And there is some study with BRAF inhibitors that have the same effect as a TSH withdrawal, that it does impairs the targeting of the and this importer. And there are some other promising agents like beta-catenin, but obviously it kind of adds to the picture that it's not an easy, but it's quite a complicated task, and there are many targets. And the question is, in which direction should we go? So, is it really an easy task with complicated methods? I don't think it's an easy task. So the question is, okay, so maybe we have some scientific rationale, maybe we should kind of investigate it, but in what kind of patients we should adopt this strategy? So the one, obviously, I would say it's for the patient that is iodine refractory. There is a minimal disease. Let's say the lesion is less than 1 centimeters, and it's slow growing. So obviously, instead of going into the drugs that are very toxic or many times toxic, like lymphoma, something that I do, or chemotherapy, I think it's an interesting strategy to kind of use it with hopes that obviously we can put in the remission. The second strategy, obviously, is if you have a iodine refractory thyroid cancer, that those lesions are bigger and you're trying to shrink them. And obviously the third one is that I was presenting this patient, the nuclear medicine doctor, who's iodine naive. There are some patients that we know because of the high risk in the scan, that the chance for them to respond to the just iodine and nothing else, obviously, is not going to give them an excellent prognosis. So those are kind of the patients that obviously this strategy would be very interesting and obviously something that should be investigated. But what are the challenges? So, I mean, one of the challenges is obviously that you want to make sure that you know that when you're going to open those doors with all those drugs, that the tissue that the iodine is going to be attacking obviously is going to be sensitive, because the tissue can be resistant. So we don't have any clear understanding, and we don't know which of those patients obviously they have a true iodine resistance, and what is the biology behind this. And obviously we have some patients that even though we deliver the iodine, the disease is just progressing. And we have patients that obviously we are unable, even with all those drugs, to restore the iodine uptake, even if we have all those sophisticated keys. And obviously, this is one of the challenge. So what are the future directions? I mean, obviously, it's quite a question because the data is kind of limited. Should we still try and restore the radioactive iodine sensitivity? Do we have enough data to kind of justify the cost and the effort? Obviously, this is one question. Should we use single agent therapy as, you know, what I presented with selatumumab or BRAF inhibitors alone, or should we give in combination, because it seems it's not really such an easy task? We have to consider the cost of those combinations. And the third question, the last question is, should we give those drugs, I'm referring to BRAF inhibitors or any kind of drugs, in the short-term basis, followed by the iodine administrations, or we should continue even after, because obviously they have the anti-cancer potentials. And all this, I just want to present in the settings that there are some other drugs for which we don't need the iodine. Sorafenib gives us the response rate of 12.5% with the PFS of 10. Lenvatinib, I have to say it's a toxic and challenging drug, but the response rate is 65% with the PFS of 18 months. And duration of the response with lenvatinib is about 30 months. So patients that they do respond to lenvatinib, they have no progression for like 3 years. And then on top of this, we have these new drugs that are given to patients if they have those mutations. So NTRK inhibitors, the response rate is 87 and 57% for the one that I mentioned. We have a 12 months follow-up, so we don't know what is the long-term effect of those drugs, or the RET inhibitors that were just approved not just in MTC but also in DTC with the excellent response rate. So the question is, should we really put more effort into the radioactive iodine restoration, or maybe we shouldn't? Maybe we should just go with all those drugs, identify the mutations, and kind of go this way. So having this in mind, I just came across just yesterday when I was preparing this presentation. So one of those drugs that I just mentioned as a RET inhibitor, NTRK inhibitor, was published in New England Journal of Medicine. So this patient is 64. She has 34 a history of papillary thyroid cancer. She received 1,400 of millicurie of iodine. She got how many? 8 treatments over 12 years. So I was like, it's a pretty hefty dose. What was interesting, that before patient was on lenvatinib, so one drug, followed by NTRK inhibitor. Patient didn't receive, at least not according to the article, any subsequent dose of radioactive iodine, but they did the iodine scan, and it looked like that treatment with NTRK inhibitors increased the iodine uptake. So the question for this patient, even though she received 1,400 of millicurie, should she get another dose? I don't know. So I just want to finish with this. After 1,400 of millicurie of radioactive iodine, maybe just sky's the limit. I don't know. And I just want to thank you. And if there is any questions that you guys have, I'm more than happy to answer.
So it looks like we don't have any questions in the chat box yet. So if people just want to unmute themselves and go ahead and ask a question.
Yeah, Krzysztof, thank you so much for walking us through these complicated studies, and then letting us know, sort of like digesting it down to really a lock and key. And then it's really fascinating to see the realities and then also the difficulties or challenges of some of these clinical therapeutics. And like you said, even just getting iodide into the system, you go like, yay, that we got it, but are we really doing anything with it? Do we need to do iodide resistance? And that's quite a bit of a challenge I see. And I think for our fellows, I think this has been a really great learning experience, because so many times in our clinics we go like, oh, it's no longer avid. What can we do? Well, send it to oncology. So this is where we see the next steps, and really understanding what goes with these patients beyond the initial treatment.
And many times when I have those patients, I always say, because the BRAF inhibition, for the cost reason and the side effect reason, is a short-lasting treatment. So in my head, I kind of justify this approach. So I tell them, I can always give you BRAF inhibitors after without iodine. Let's try it. So I'm still believing in iodine, and obviously with the TSH suppression, so we're still trying. And we have some successes, but we have some failures too.
All right, so it looks like we do have some questions rolling into the chat. So the first one is there a role of immune checkpoint inhibitors in radioactive iodide resistant thyroid cancer?
That's a good question. So a few things that I'm going to say. I'm asked about the immunotherapy in settings of iodine refractory patients, so meaning somebody who is either not eligible for any kind of oral treatment or somebody who fails subsequent treatments. The data is not very promising. It's not a very active drug, with one exception. There are a few drugs, and immunotherapy is one of them. When somebody has a MSI high, which is a microsatellite instability, regardless of the histology of the cancer, doesn't matter if it's a thyroid, if it's a pancreatic, then there is a chance that those patients are going to respond. And I know that I'm not answering directly. So only for those patients, immunotherapy seems to have some kind of efficacy. In general, in thyroid cancer, I'm not aware of any data of using immunotherapy as a method to restore iodine resistance. I don't think so that we have this data anymore. But something on the side, I can tell you that we know that for example, anaplastic thyroid cancer, and this is not FDA approved treatment, there is a huge mutational burden. And we know immunotherapy is more effective when the mutational burden is high. As an example, when you're gonna have a squamous cell carcinoma of the head and neck, lung, and skin, and it's all squamous, skin is the one that's gonna respond the most just because of the mutational burden. So going back to anaplastic thyroid cancer, I have given immunotherapy in anaplastic thyroid cancer. I'm not gonna say that I cure those patients, but it isn't an active drug. But to answer your question, there is no data about restoration of iodine with this method.
Okay. Follow-up question is Sinai conducting or participating in any of the trials that you mentioned during your talk?
No, so yes, we did. So we were part of the Salatumumab study. So that was the randomized phase 3 study. So we're part of the study. As of now, we don't have any study. Those studies are quite challenging and with kind of a minimal reward. So obviously, yes, if anybody's interested, this is what I'll say. We don't have any study open, but there's many fellows or residents. If you're interested, if you want to write such a protocol, I would be more than happy to help you. And if you want to open, absolutely, we can do it. As of now, we don't have any clinical study.
Question from Dr. Brito. So you mentioned the possible utility for low volume or slowly progressive disease. Is it your perception that there may not be a mortality benefit, understanding that the short-term follow-up has been very limited in this regard?
Yes, I mean, obviously, because we know that the mortality is still low, but obviously we kind of, as physicians, we are greedy creatures, so we want to improve our results. So yes, I think in those kind of patients that the toxicity can be justified because, again, these patients usually receive the BRAF inhibitors or any kind of TKI or any kind of treatment that I give, let's call it targeted therapy / chemotherapy. It's a very short course. So I think the toxicity can be justified. So that's why and obviously if the iodine will help, I think it's worth pursuing those patients with this method.
Great. So those are all the questions in the chat box for now. So if anyone had any, we still have about 8 minutes remaining in the Zoom. If anyone has any other questions, please unmute yourselves and go ahead.
I'd like to ask a question. Thank you so much for the talk. With regard to this short-term therapy, I guess even 2 questions. One, I would like to hear your view on the risk of inducing resistance to whatever drug you may choose if you give it for a short time and then maybe want to give it later on if it's not responsive. And second, I don't think there are, but have you seen any, maybe say cell culture studies or something investigating, given the cost of these drugs, perhaps we don't really even need 4 weeks. Maybe we could get away with 1 week. Are there any studies looking how fast thyroid cancer cells may start expressing sodium iodine symporter?
Sure. I mean, the first question is absolutely excellent. Because even though I would be the one prescribing the BRAF or any kind of TKI to those patients, but I can mess up my own life by creating some kind of resistance to those drugs. And yes, and even when we use those drugs, we have a tendency, because some of them, they're toxic. We like to start high, and many times we have to dose reduce them, having the resistant kind of mechanism in mind, because obviously you don't want to create some kind of a clone that's going to be resistant down the line. So yes, this is a very, very valid concern. And this is something that was not studied. I don't think so. I'm not aware of any other study in the cell lines that the shorter course of those drugs is providing any benefit, but it is an excellent idea. And obviously, we don't know if we need 1 week, 2 weeks. It's kind of arbitrary. So, but yes, it would be nice. So, as of now, we don't have those studies yet. So this is another idea for the fellows if they want to do it. We can have the randomized study with the short course and the longer course.
I have a question for you. Thanks for the talk, Chris.
Andy.
You touched on this, but a patient, 37-year-old, otherwise healthy, female with a papillary thyroid cancer, bilateral neck metastases, bulky metastases, undergoing thyroidectomy and bilateral neck dissection, and pulmonary metastases as well. And so when you approach a patient like this, probably she's radioactive iodine sensitive. We don't know that yet. But from the outset, in a young patient with widespread disease like this, will you think about giving her more than just radioactive iodine presumptively, in the first phases of her treatment? And, with radioactive iodine sort of being the standard historical treatment for a patient like this, we would normally start with a high dose of RAI. Is that the right way to go? And then, how soon after do you offer her something else? Do you wait and see if there's a response? How long do you wait and see if there's a response? How do you make that decision?
It's not an easy task. So, I mean, with those patients, if I have somebody young and obviously they have the widespread metastatic disease and the iodines can show some concerns, and obviously with the young person, you want to be aggressive, then they have a tendency to be aggressive too. And obviously this is not the FDA approved drug. So I just put the cards on the table. I tell this lady that you have the one-time shot. If we're going to give iodine alone, we cannot go back in time and then give you salatumumab and give you the iodine again. We have to make a decision now. It's like with concurrent chemoradiation. This is the time to make a decision. But at the same time, obviously, I tell them that obviously that the price is not very high in terms of the side effects. Yes, it can complicate my life down the line because we can create resistant clones, but this is your chance. So I have the tendency to be aggressive, but obviously I have to have the patient consent for such an approach. And I would be, yes, why not give it a try? And obviously it has to be always, I would say, paired with the genetic testing, because I don't think that I would feel comfortable, even that, in the salatumumab study, there is some patient with a wild type and they gave salatumumab, and there was one patient out of 3 that responded. I don't think they would feel comfortable giving a targeted drug to a patient who has no mutation or has different mutations, and we're not going to be able to target. And I can actually make a comment on this. But with the mutated patient, yes, this is the way I would go. How I follow up those patients? Very, very closely. This is what I would say. So yeah, so we repeat the imaging, we follow the thyroglobulin, the PET scan. And if it's a very, very wild spread disease, already knowing that I have a genetic testing, it kind of makes my life a little bit easier. I have something in my sleeve that eventually I can use. And this is the good point, because let's say I'm going to give the BRAF inhibitors to this patient with iodine, and then 3 months or 6 months later, patient is progressing, I'm giving BRAF again. There is a concern that obviously some of the clones are going to be resistant. So yes, there is some risk embedded into that. And actually, the first patient, so this is what I'm going to say, the first patient, the nuclear medicine doctor who is iodine naive, he has a BRAF mutation that is not V600E. And all those inhibitors, they target this specific mutation. This patient has 486. So what I did, I looked up on the PubMed, and there is 12 patients with this mutation, 486. None of them has a thyroid cancer. All those patients, they had pancreatic cancer, they have ovarian cancer. Response rate in metastatic settings for non-thyroid cancer with BRAF inhibitors is about 50-50 chance they're going to have the response. So here I have a physician, iodine naive, and he has a BRAF mutation that is not the one. It's sort of like, I'm trying to jiggle with the key with hopes I'm going to open. So I just put the cards on the table. So with him, what we're going to try to do, we're going to try to attack with BRAF and MEK inhibitors, because MEK is just one step below BRAF. And he's fully aware that this is his only chance. So I'm kind of willing to bite the bullet. But the patient has to be fully aware about the risk and the consequences of this.
Makes sense. Just one technical question on that then, which is, in a patient like this, we normally will get a needle biopsy and it shows PTC and we're off to the OR. we haven't synthetic analysis. There's no need. So then do we get a genetic analysis? Do we ask for one? Because they're not routinely run in the pathology lab. Do we ask for one at the time of the operation? Do we put that on the pathology request form? Please do a genetic analysis, or is there anything more that we do?
Sure. So I'm going to clarify because, for example, I had a patient that claimed that he had a genetic testing because he had a Thyroid. And as you know, the Thyroid does not give us the mutation. It just gives you the percentage, right? So I don't want you to think that the Thyroid is equivalent of the whole genome sequencing. The Thyroid helps us in a completely different scenario. But yes, it's not something you can write, but there is an epic order. Obviously, you can use any kind of vendors. There are so many of those companies. Foundation and one is one of them. We have Semaphore. This is the Sinai company that do the genetic testing. And you just have to go to Epic and type Semaphore, and you just fill the form, and it's going to be done. Maybe it's not the easiest form because there is some information that has to be typed in, but it's doable. But and it takes another thing to kind of for you guys. If we're going to order the Semaphore, it takes about 4 weeks for us to get the results back. Since those drugs are oral and many times are not FDA approved, it takes another 2 weeks to fight it with the insurance. And it takes another 2 weeks for the drug to be delivered because it's not the drug that you go to the local pharmacy, it has to be mailed. So many times it's a kind of a time battle, obviously. And with DTC is not the problem, but you can imagine when I have the anaplastic thyroid cancer who has a BRAF mutation, and then I want drug for yesterday, it's a kind of completely different scenario. But yes, having the genetic testing done earlier would be helpful. The question is, will the insurance cover for this?
Thank you.
All right. So on that note, we're at the top of the hour. Thank you so much for a great talk.
Okay, thank you so much.
Thank you, Chris.
Bye.